right, thanks, Elizabeth. So I'm gonna share my screen here. Takes me a second to set up because I want to make sure I can see the chat when we go through this. Really, my goal is just to provide some information to get conversation started and to offer an opportunity for questions. You have a captive psychologist for an hour, so anything that you can think of that could be helpful to your practice, feel free to ask as we go through. And I'll ask Elizabeth and Laura, if you don't mind, if I'm missing questions that come up in the chat, please unmute yourself and just ask me. All right. So we're going to talk about in-home safety plans today. Do I need to click this a little bit differently, or are you seeing the big picture or the big picture in the preview?
We are seeing the big picture in the preview. Go, I can barely see it. I think slideshow to the right. No, don't end it, sorry.
Oh, yeah.
Yeah, you can just, you should be able to.
Presenter view?
Yeah, there.
Am I good?
You got it.
All right, great. So to give you a little bit of background, I'm a psychologist and I'm on the faculty at Marshall's Joan C. Edwards School of Medicine in the Department of Family and Community Health, which not only houses our family medicine and our community-based health programs, but also our division of addiction sciences, which is a little bit unique for medical school. A lot of times those are attached to the Department of Psychiatry and Behavioral Medicine. In Marshall's case, because of our patient population, substance use disorder is really a primary care issue, and we try to treat it as a chronic health problem, kind of within the same continuum of care as our other family and community-based treatments. So part of my role within family medicine is that I'm our behavioral health integration coordinator. So helping our residents and our physicians to treat different mental health conditions in primary care and also within our SUD programs. My responsibilities over on the division side tend to be around our outpatient programs that are our intensive outpatient / wraparound services for pregnant women, pregnant and parenting women with substance use disorder and their very young children. So that's my population. Some of my resources that I share about today might be skewed toward that, but feel free to ask questions outside of that, and I will answer those to the best of my ability. To give you a little bit of background, before coming to Marshall, I did predominantly forensic evaluations for DHHR and family court. I know that in this series, you'll have the opportunity to hear from another provider on psychological evaluations of parental fitness. But during my time with Cliff Hudson in Charleston, I did over 1,000 of those. And so that was kind of my introduction to CPS and the different kind of combinations of case plans that families could have. And now on the provider end, trying to do more prevention and keeping families together to the best of our ability. My perspective is a little bit different, but I'm going to try to include both of those perspectives. I'm going to open the chat, and it would be really helpful if people can just kind of put a word in the chat if you are more of a mental health provider, legal professional, CPS, even just a one-word answer. That'll give me an idea of kind of how to skew today. Oh, good. So already we have a good combination of both therapists and CPS. Awesome. A lot of case management. In a previous life, part of what actually urged me to go back to graduate school was doing children's case management. So I see that side as well. Okay, awesome. So we've got a lot of different perspectives. So please, like I said, ask questions. I'm gonna go a little bit quickly then through the legal requirements because it seems as though that's something that people are more familiar with, and try to give a little bit more time to talking about cases and giving people opportunities to ask questions about things that might be helpful to families. Okay. As far as disclosures, I have no financial disclosures. Marshall will not pay me enough to lie to you. Okay, our learning objectives. So we're going to talk about requirements, when in-home safety plans can be utilized as far as policy. Family strengths. So what are things that you want to look for and build upon with families that may be eligible for an in-home safety plan? Resources, what kinds of resources to include. That's going to be different depending on what region that you're in. But there are some strengths that we as a state have that I'll touch upon in that section. And some example plans. So I just pulled 3 plans for folks that I thought were really good examples of being able to keep the child safely in the home with a combination of different services in place. Okay, so I will not read this block of text to you, but essentially for CPS policy, an in-home safety plan can occur anytime that the impending dangers that were found in the home during the investigation process can be remediated or prevented from escalating by keeping the child in home with the addition of services. In-home safety plans do allow for there to be periods of time when the child is maybe outside of the home for things like respite, childcare, going with another parent or relative for certain periods of time. But the idea is that the child will stay in the home while these services are being provided. Okay, so there are some requirements according to CPS policy that I think it's important, even for those of us that are in a therapeutic role with the families, should know about, because if the parents are unaware of these things, we can help to advocate for them, not necessarily to cause any kind of friction with their worker, but just to make sure that everybody's on the same page. And I'll give some concrete examples of that when I get to the end of this slide. So it's required that it's a written document between the parent or caregiver and the department. It specifies what are the impending dangers that were identified during the investigation. Specifically, you have to name both the formal, so services, for example, and informal safety resources. That can be family members, it can be friends. I'll talk about some of the community-based services that we have emerging in Huntington that would be examples of things. If you have an analogous program wherever you are that you might include that you wouldn't maybe have automatically thought to include, but informal safety resources that will provide services. So anyone who is going to provide the services needs to be named in the plan. The roles and responsibilities of the safety resources, both informal and formal. So it specifies what they are to do, not just that they're a resource, including a description of the availability, accessibility, suitability of those involved, and the actions or services, including frequency and duration. So it's very analogous to a treatment plan. Is there going to be someone there once per week for an hour, 3 times per week for 4 hours? What is going to be the frequency and the duration of each of these safety resources that's included in the plan? You also, if there had been a temporary protection plan, like a 7-day plan before, making sure that any of that that's going to carry over is included into the in-home safety plan. Explain to the parents how CPS will manage or oversee the safety plan. So what would the consequences be, for example, if they do not comply with the safety plan? And how are you going to follow up? So how are you going to communicate? If the therapist is on the safety plan, you should talk to the parents up front about how you're going to communicate with them. And the plan also always has to be approved by a supervisor. So here's where I'll editorialize a little bit about, and this is not a blame game. This is putting cards out on the table, and I hope that you all will do this as well as far as exposing difficulties. I know that providers sometimes are difficult to work with on these things, but maybe we can find some solutions that will be mutually beneficial for all. So sometimes I have patients that for one reason or another do not have a written copy of the safety plan. And so they're either relying on their memory or their understanding or, what they believe that their CPS worker told them at the time. I believe likely that a lot of those times, knowing my folks, probably didn't ask for a copy and probably don't remember if they signed a copy. However, it's really important that everything be specified, because this is an agreement on how we're keeping the child or children safe in the home. So if I'm named as a resource because I'm a therapist or peer or some kind of in-home service provider, and I don't know what's on the plan, I can't guarantee that I'm actually doing what I'm supposed to be doing according to the plan. So anytime someone gives an inkling, hey, my worker wants me to keep coming to this program, I want to see a copy of the plan. If the parent doesn't already have one, I will help them. Maybe we can get on a three-way call and call together and see if they can get a copy of the plan so we know what's going on. As far as formal and informal safety resources, that's another common issue that I see, is that a friend or family member will be included as a resource and either not know that they're a resource or not know what their responsibility is. So it's important for those folks as well that it's spelled out what exactly they're supposed to do. A concrete example of this is we've had a family where the safety plan, which we did have a copy of because we thought ahead and we requested a copy, but there was a grandparent or aunt, someone like that was supposed to be in the home a certain number of hours per week, and they went on vacation without telling CPS or anyone else. So they violated the safety plan, but it seemed as though they really didn't understand what they were agreeing to. So it's really important, if you're going to be included in the safety plan, to try to know what your roles and responsibilities are. And in terms of communication, as I said, my kind of role with working with families that have CPS cases now is really mostly through the parents' substance use treatment. And so we have different requirements for how much information we're allowed to disclose and what forms we use to document those disclosures. And I don't know that everyone knows that. So, for example, we have a regular Marshall Health release of information that you would fill out if you went to a new doctor's office and you wanted them to send the records to your new physician. That's one form, but that's not the form that you need either for therapy records or for substance use treatment records. Those are actually require 2 additional forms. And so if you're going to be utilizing community providers as part of the safety plan, or you're wanting the parent to stay in a certain treatment program as a condition of the in-home safety plan, you want to make sure that you have the correct releases for whatever agency you're going to be using. And to keep in mind that someone may not be trying to be difficult by not giving you certain kinds of information, but they may legally not be allowed to give you certain kinds of information without either an appropriate release or a court order. And our goal with the in-home safety plan is to try to prevent taking it to court. So we want to try to get that done ahead of time. Just like the providers want to have a copy of the plan, the CPS worker, attorney, or anyone else who would be, although I guess you're trying to, if you're not in court yet, you may not have an attorney, but anyone who's going to be overseeing this plan wants to have the appropriate releases. We want to have what each other has, basically. Any questions just on this part of the requirements and making sure that we're all on the same page about requirements? Okay. Has anyone had difficulty getting records? from a therapist or a psychologist. You can just drop it in the chat. My impression is that this is kind of a continuous problem. It's hard, and so we do our best. But I think if you know that in your practice that you work with a lot of families that have CPS involvement, being aware that you may have to kind of have a packet of releases ready to go when you onboard someone into your program. So that if you are supposed to be giving progress reports to their worker and their worker is expecting those progress reports, that you have them sign the appropriate releases, including if you're a substance use treatment provider, the 42 CFR Part 2 release that has that specific lines of exactly what documents over what time frame you're allowed to release. So for example, if I have a release that allows me to verify that someone's in the program, but we didn't specify on those lines that you're going to be getting monthly drug screen reports, I can't release the drug screens without a court order. So we have to make sure that we know what we can give each other and how. All right. This is also part of our state policy. Now, this one that I have directly taken from was updated in 2019. We also have publicly available the CPS policy from 2020. I didn't see any changes there for in-home safety plans. There is one more up-to-date state policy from 2022 that has a lot more nuanced information about the investigation phase and how different problems should be handled in the investigation phase, but I did not see any updated information about in-home safety plans. So this should be most current. CPS should inform parents about their rights related to accepting or cooperating with the in-home safety plan, as well as any alternatives or consequences. So this is prior to, and hopefully it would prevent a court order. So this is in some sense voluntary, just like therapy is voluntary. Even if you're court ordered to do therapy, I can't tape you down in your chair and force you to do the therapy, but there could be consequences for you if you don't follow through with this agreement, and so they should be aware of what those consequences are. And we're trying to be the least intrusive possible. So you want to work with it to engage the parent in understanding and accepting the need for a safety plan. You want them to understand why are you making them do all these things. And you want to get the parents, not just their buy-in, like their agreement to do it, but their input. So if they don't want to change therapists, or they already have some kind of in-home visitation, we'll talk about different kinds for itty-bitties, my patient population in a minute, but if they already have a good support, but we just need to formalize to make sure that they're actually getting the frequency and intensity they need, we want their information about what is going to work for their family to the extent possible. And if there's an informal safety resource that we think is appropriate, we want to include that too. So we don't want to force the family to do things completely differently than what they're already doing. If something that they're already doing is working, we want to just enhance that and formalize that. And so this is where we're going to look at what the family's strengths are and try to match onto that. So Laura asked a question: when an in-home safety plan has been successfully completed, should the client also receive written notification of that? And what is their recourse if that does not happen? So like all agreements, you know, this is a legal agreement in a sense. It's not as formalized as a improvement period, for example, that the court, you know, has to authorize, but it's like a contract essentially. There's a time frame involved. So I've seen 90 days. I've seen them extended from 190 day, we're going to check in and then do it another 90 day. And the goal is to remediate these issues in a reasonable enough time frame that it does not need to escalate to a court case. So I've seen the 90-day increments tends to be when it is renewed. When your case is closed, you should receive written documentation of that. That is another situation in my experience where that does not always happen, or it's very unclear when the case is actually closed. And again, this is not like a blame game situation, because I think sometimes people hear what they want to hear. And so they may hear, oh, hey, things are going good, I'm going to close your case, open-ended, and interpret that as my case is being closed. But if they don't have that letter, I would not feel comfortable asserting that that is true. Recourse, I always recommend, if people are having a hard time getting in touch with their worker, to try to get in touch with the supervisor at CPS who may be able to help. So there should be, I know a lot of counties are very, woefully understaffed. We're very lucky in Cabell County. I don't want to underestimate that for some folks, but there should be a supervisor available to answer questions pretty much any day of the week during normal business hours. So that's what I would do. If the patient felt very certain that they had been told their case was closed, but they had no documentation to prove that, that's what I would do, is ask the worker first. And if you can't get a hold of them for an extended period of time, I would ask, just, can I speak to a supervisor in child protection? And then they'll look up your case and they'll be able to let the person know what the status actually is. And so if it has been closed and they just don't have documentation, it should be pretty easy to get from that point. Does that answer the question?
Yeah, thanks, Jen.
Okay, so we want to identify what the family's strengths are so that we can map the resources onto, like, fitting in like puzzle pieces. Like, you have this, you need this, let's match them appropriately. And it's challenging with families that are highly stressed. Maybe they have a lot of, in some ways, thinking of strikes against them, to think about what their strengths are. But any family that's going to be appropriate for an in-home safety plan is going to have some kind of strengths. Otherwise, they're not appropriate to do this to begin with. Okay. So number one is a safe home. The home has to be habitable. If the home is already unsafe, objectively unsafe, and it can't be remediated within 7 days, that's not going to work. So having a safe home is a strength. And one of the things that we want to do is help the parent to either maintain their safe home, or if there's maybe less preferable situation with that home, trying to find alternate housing that is still appropriate. Housing, this is me backing off and putting my provider hat back on. Housing is the number one thing we work with families on. And we try, one of the programs that I oversee is our pregnancy program. And we try, if the mom is not already in safe, suitable housing, that's the first thing we work on, because it takes a long time. It's resource intensive, and we want to make sure that at the very least the mom has a safe home, so that she would be able to receive services as opposed to having to look at a removal at that point in time. That's not what we want to do with a newborn if we can prevent it at all. So safe home. Physical health, we take that for granted, but if parents are physically healthy, that is a huge strength that we can pull upon. Having any source of income, whether that is employment related or TANF, child support, having some level of income is a strength for a family. Because if they have an income, especially wages, that opens a lot of doors that not all of your patients are going to have, or clients in the terms of case management. Not everyone on your caseload is going to have some kind of income, or specifically wages. That's a huge advantage. If they're already connected to economic supports such as SNAP, Medicaid, if they already know where to go for emergency food pantry, emergency clothing pantry, that is a huge strength. It one of the things that we see a lot in the greater Huntington area, and I saw Alicia Bowman sign on, so I know she can corroborate this, is that a lot of folks do relocate here because we have resources, but then it's really challenging to figure out how they work in a different community. Every community has its own unspoken rules and challenges, and well, really, it's the hours say this, but if you can get here before this time, that's really when you're going to actually get something accomplished. Those are all things that when we're embedded in a community and we are using, making the same referrals on a regular basis, we take for granted, but not all of the folks that would need this kind of plan know those things. Or maybe they don't have transportation, they don't have their identifying documents, and that would be something we would want to do to get them to the point that they can use these economic supports that are already available. And I'll also kind of back up and say, in our official state CPS policy, as far as payer source, I'll talk about ASO services, which is like a special bundle of services, but really any payer source that is open to the parent can be used. So if the parent is already eligible for LEAP or already has a medical card, you don't necessarily have to find new ways of paying for these services. They may already be eligible for services that they're just not already getting. The presence of a family bond, that is a huge strength. We work with a lot of families where there's been a prior removal, and so maybe they have certain children in their life that they have not seen or have not seen regularly for years upon years. So if there is already a close familial bond between the parent and the child that you're trying to increase the safety for, that is a huge strength. If the parent has a commitment to their mental health or substance use recovery, so if at the time you come into contact with this family, they already are in therapy, they already are receiving treatment, and they want to continue with their recovery, that is huge. We cannot guarantee that for all families, unfortunately. If the family has social support, that's a huge strength. If they don't have the type of social support that a lot of us take for granted, so maybe their parents are not living locally or not appropriate to use as a safety resource. Maybe their parents also have active substance use disorder. We're going to have to find other means of getting them social support. But if they already have social support in their life, that is a huge strength for families. Having adequate adult social role functioning. So I don't know that we use this term much anymore. This used to be part of the FFA, was looking at the adult social role functioning. So can they go to work? Can they maintain a habitable home environment? Do they have very basic parenting skills? So can they function as an adult out in the real world? And what I'm seeing in my practice is at this point, the people that we think of as being kind of the victims of the opioid epidemic, a lot of them are around my age. I'm in my early 40s. Their kids are starting to have kids, and those kids were raised without functioning adults in their life. So some of them lack very basic things of how to open utilities, how to get a driver's license, things that a lot of us would take for granted. So if a parent already has that in place, but maybe they're experiencing an exacerbation of a mental health condition, or they're having a return to use of substance, but they have that knowledge already built up, that is a huge strength that we can draw upon that we might take for granted if we're not looking at it that way. Motivation. So as when we looked at the policy earlier, the parent has to be able to understand, why are you asking them to do these things? So if they acknowledge that there are areas of their functioning that are not optimal, or if they acknowledge that these stressors that are deteriorating their functioning, if they acknowledge that those are things that can be changed and should be changed, that is a wonderful starting off place. Because if they are willing to work with you, they understand why you're doing this, you can really draw upon that motivation to get the improvements that you need to see to safely close that case. Whereas if from the very beginning, they're not willing to admit what you see right in front of your eyeballs, you might not get very far doing in-home. Being in a community where there are services that are available that will address whatever deficits you're identifying. Not necessarily deficits, I think that's probably, you'll address that more in the parenting, parental fitness presentation, but the impending dangers specifically. So if the impending dangers are that, you know, some of the family members are in a wheelchair and there's no ADA accessible entrance to the home or exit from the home, or there's exposed wiring, but in your community, you happen to have a church that's extremely active and willing to work at making repairs, that's a huge asset that the family has. Living in an area where you can get them an appointment with a psychiatrist is not something to take for granted either. So if those services are in the community, that is even more reason why we wouldn't be able to look at doing an in-home safety plan. And the parent having the ability to acquire, use, and generalize those services. So even though that is something that is going to come to light more over time, you're not necessarily going to know this when you first meet the parent or even over the course of the investigation. The investigation usually takes around a month. You may not really know the parent well enough until they're in that case management phase of where you're overseeing their plan. But when you're overseeing their plan, if you're seeing that maybe this person has such severe deterioration of their mental health functioning, maybe they need to be medicated because they are having a significant barrier. They're participating in the services, but they don't seem to be getting anywhere. Whereas if you have a parent that you tell them to go to the food bank, they go to the food bank. You tell them to sign up at their community mental health center, they sign up at their community mental health center. That's a huge strength. And to me, like, that's a good indicator of a family that you want to invest resources in because they're actually responding to the plan. Does that make sense to everybody? Does anybody have questions at this point about how you want to think about what's available to you when you're making up your plan? Okay. Now thinking about resources, right? We're going to match what resources are included in the plan to the strengths and the lack of strengths, weaknesses, deficits, however you want to say it, the impending dangers, so that we are kind of providing coverage to reduce risk. So what's needed? Does the parent need home repairs, alternative housing? Maybe they have adequate housing or maybe like non-unsafe housing, but helping them to access the housing options they have available to them would increase safety or increase their ability to access some of their other services. That's something to think about. Do they have a primary care doctor? Do they know where to go if they have a mental health issue? About 70% of mental health conditions, and this is across America, this is not just in West Virginia, about 70% of mental health conditions are managed in primary care. Family doctors are taking care of most anxiety, depression, etc. I would say in West Virginia that's probably even higher number just because we're very underserved with specialty psychiatry. So do they have someone they can go to if they need an antidepressant? Do they have health insurance to go to see that PCP? Job placement services, that's something that's really exploded over the last 5 years or so. Even though you may not necessarily have an office in your county, there are programs such as CORE, Creating Opportunities for Recovery Employment, is a Marshall program where we have different catchment areas that are covered to help people in recovery to find employment. So there may not be an office that you drive by down your street, but you may have coverage for a program like that. If they qualify for economic services, how do we help them sign up? It's a great one when you start assessing the parent's needs and you realize oh, you're already eligible for all this stuff. We can do this. For if you're needing, this one was to correspond to the familial bond, right? You may need safety services. So that is typically requires you to go ahead and get authorizations for the ASO services to have things that fall under what we used to call socially necessary as opposed to medically necessary. I think a lot of us in the field are starting to see those as not supposed to be two siloed things, that maybe we can find some, not duplication, but overlap, so that certain families who are maybe not already receiving ASO services, but they may be able to get home visitation, for example, through a medical pathway. And I'll talk about, like I said, the infant home visitation programs that we already have that are available. I would say the vast majority of patients I know that have CPS cases are covered for home visitation for babies and young kids. But anyway, if there's not a service that's available through their medical card, having safety services, somebody to drop in and do spot checks and watch the family and how they interact with each other. And those folks are always supervised by some kind of licensed professional, whether that's a psychologist or a licensed independent clinical social worker. And then they prepare both notes for every visit, but also monthly reports. So you can see, is the person seeing anything? And sometimes they don't. Sometimes it's just kind of that insurance if this family doesn't have a very well developed informal support system, like they don't have the grandparents and the aunt and uncle dropping by because they don't live nearby or they're not appropriate. It's just that insurance of having a safe adult who's well trained and supervised to just pop in and see how things are going every once in a while. Does this family need parenting classes? And there are resources in a lot of communities where you can get the parenting classes even without a court order. In our community in Huntington, Willie's Place offers parenting classes and prenatal education classes without having to get authorizations for ASO services. They are separately funded. So maybe some of your lower risk families would be able to do parenting in that way without necessarily having to get authorizations for the individualized parenting. We're still doing good on time. Child and family therapy can be really hard to get, but I would say try to get to know the therapists in your community. So if you know that your organization, and this is more for the person writing the plan, right? If you are someone who writes these plans or reviews these plans, even in like a historical sense, like you get them as part of your court file down the road, you want to know who these people are that are getting referred to all the time. So can you pick them out of a lineup? Do you know what their background is? Do you know what their philosophies are about treatment? Do you know what types of evidence-based treatments they use? Do they come to court? If you subpoena them, will they come to court? You want to try to get to know people that you know are going to be effective. And I know that's very challenging because most of our both healthcare workforce and child protection workforce are super overworked and underpaid. All of us are. So it's hard to make those kinds of relationships. But when you have them, it's much easier to know, oh, this person would be a great fit for this family because they do this type of therapy. For example, parent-child interaction therapy, which I know that comes up a lot in the various trainings that those of us on this call do. Laura and Amanda talk about PCIT as well. So sometimes there are specific types of therapy that can work to improve safety for specific concerns, depending on what those are in the home. Do the parents need referrals for mental health or substance use treatment? What kind of social support and community supports can we put in place if they're not already getting them? And this is where I'm saying to be a little bit creative with what you have. So in the greater Huntington area, one of the things that we have that we didn't have, say, 5 years ago is a recovery cafe model. So it is kind of I would say like a an outgrowth of, it's not exactly the same as, but an outgrowth of, say, a drop-in center model, where it's a lower barrier community support. Our local one is Recovery Points Point Cafe, and essentially Monday through Friday, I don't know the exact hours, but like, 8 to 5, regular business hours. There's always groups running. There's always peer recovery coaches available. There are always people available that can help people to fill out different forms. And they have a lot of patient incentives for participation. So if you enroll as a member, you're somebody that goes there every week, that opens up certain like financial incentives to help you do things like, I don't know, say get your license back or things of that nature. And so that might be something that you wouldn't necessarily think of as a safety support for a child, but if the parent is able to be in this safe, sober environment for multiple hours out of the week, that is a different kind of social support that can be implemented. And we've started putting that into our treatment plans, that a lot of our patients are then communicating with their worker they want on their in-home safety plan. Do they need adult life skills? There are ways of getting certain types of adult life skills, mostly vocational, but there are other places that I see things like financial literacy that are given. Again, without necessarily having to activate ASO services that you might already have access to in your community. Is everyone on the call familiar with Marshall's, the Center of Excellence Behavioral Health Workforce Training Center? I'm just looking at the chat if you see me making faces. So they provide training statewide about a lot of the newer programs that are coming out. And so that would be a good resource just to get a refresher on maybe what kind of, say, a financial literacy class or soft skills work skills class might be accessible to your clients. If the family is having difficulty with motivation or with acknowledging some of the issues that are going on, during individual therapy, we frequently address things like motivation. I just would not necessarily, without having that open line of communication, I wouldn't necessarily assume that that's what's going to happen in therapy. So sometimes if there is not that communication, if it's not written down on the in-home safety plan, what kinds of things need to be maybe addressed or should be asked about in therapy, the patient can go say like, well, I'm really sad because I don't like dealing with CPS. And so we're going to spend 8 sessions talking about how sad you are dealing with CPS, and we're going to miss the whole point of why you referred to therapy to begin with. So if you can give any kind of assistance with localizing the problem, that can be really helpful in terms of putting together a plan that's really going to affect changes for families. Do we need to be creative? Kind of, again, using that recovery cafe as an example. And with learning issues, if you're noticing that the person is struggling, they're starting to do some things, but they're not getting the improvement that you're expecting, can those learning issues be addressed via existing resources? So, for example, adult literacy classes, or again, a lot of times the vocational training classes that we have, not just with CORE, but Division of Rehabilitation Services. I don't know if folks refer there at all. They're amazing, the things that they have helped my clients with, and they really do meet them where they are, as far as if they need to be taught how to put together a CV, how to look for a job that will accommodate their disability. There are a lot of existing resources where we can kind of help families that are not responding the way we initially hoped they were going to respond to the resources that are in the plan. Because of time and because of our audience, I'm going to ask, does anybody have questions about ASO services, or is everybody familiar with that term already? And I'm looking in the chat, so I'll give us a minute. So the ASO services are also what you hear referred to as socially necessary services. If anyone who's as old as I am has probably heard the term special medical card, which is typically in the past how we pay for these things, where it's essentially almost like a waiver program. It wasn't called a waiver program, but the state's going to pay for these certain bundle of services because it's socially necessary to stabilize this family. And do we have any socially necessary providers on the call today? I see some peers and stuff. I'm not sure what you work for, but ASO providers can be really great. When I worked for Cliff Hudson, we had a socially necessary services program, and they do a lot of the heavy lifting, specifically when it comes to court cases. So they supervise a lot of visits and parent-child interactions. They do a lot of transport. They do a lot of the in-home services, and those are very important. But my take-home message to everyone on this call is don't overlook what's already in your backyard, particularly if the family is already showing some participation in services. So these are things that can be added if they're authorized. In my experience, sometimes there are delays in getting these authorized, especially if it's outside of a court order. So if you're doing an in-home safety plan and it's outside of a court order, sometimes there are delays, sometimes they're not. So I've had clients that they get these through the RPG and they're initiated right away and there's no delay at all. So these are things such as supervising visits, individualized parenting instruction. So in addition to parenting classes where you get kind of general information over a variety of skills, the actual individualized parenting in the home is going to kind of on a rolling basis, as they see how you're doing with certain concepts, be able to coach you in other directions, or be able to bring back, if they're not a licensed provider, bring back to their supervisor. Maybe we need to spend a little bit more time on something else, whether that might be this child has a disruptive behavior disorder, or there's something more going on than kind of basic behavioral parenting. Crisis response, crisis home management, social and emotional support, emergency respite, transportation. That is a great service that is activated through ASO, and child-oriented activity. That's in the policy that I saw as of 2020, but I've not seen families getting child-oriented activity lately, but that may just be my area. But child-oriented activity, when I did used to see that a lot, is typically in youth services cases where there is a provider that is coming into the home and working with the child, doing more like supportive intervention as opposed to traditional therapy. Okay. So here again is where I want to underline the highlight of look at what resources are already available. And I know we have a lot of therapists on this call as well. So if you have a family that needs more support, even if CPS is not involved, these are all things that we can recommend for our families to help add support to what we're already providing. Voluntary home visitation in the literature is the most powerful way to reduce child abuse and neglect. And this is a finding that is repeated over and over and over again, is voluntary in-home visitation. Now, I'm not going to argue with anybody about how voluntary is it. If CPS says, if you don't do it, we're taking your kids away, okay, maybe it's less voluntary, but voluntary home visitation means it's this suite of services as opposed to putting in the ASO services, which are not really voluntary. All right, so the ones that are available, and this is in my area, depending on where you live in West Virginia, they may be called different things, and you might not have all of them, but you're going to have some of them or something similar, because West Virginia is one of the only states that provides this kind of voluntary in-home visitation programs to all children. in the qualifying age group. So that is something that we're doing right. I like to emphasize when we're doing things right for a change. Okay, so right from the start is a program that is pregnancy through 1 year postpartum. They provide home visitation and care coordination, like a case management. It is not as intensive necessarily. It's more of, but it is, they do include referrals and things like that. But the home visitation part is really where you're going to get the meat of the intervention. It's anybody who has West Virginia Medicaid can get this service, and the child doesn't have to meet special criteria. So there doesn't have to be a delay, high risk, or anything. This is a benefit of their insurance. And if mom has a substance use disorder, her insurance also pays for the mom model that I saw, the ACE program. I'm affiliated with Healthy Connections. So all of the drug-free mom and baby programs that work together with pregnant women with substance use disorder also get that benefit of some extra care coordination through their medical card. But right from the start, you don't have to have SUD or anything like that. It's a benefit of your medical card. Mountain State Healthy Families, they cover pregnancy through early childhood. They are very home visitation based. They'll work with the comfort level of the family, but home visits is the meat and potatoes of what they do. It's completely free to families. Again, does not require delay or diagnosis or anything like that. And Mountain State Healthy Families is actually one of the only organizations that I've seen be able to use that Family First Act money to be approved as part of a family preservation plan. So they have a curriculum that is consistent with a nationwide curriculum, and so they're able to utilize that as kind of a preventing removals. We really love Mountain State Healthy Families. What I really like personally about working with them, even though I'm not going to compare and contrast these programs, they're all effective, they're all good. But what I do like is they provide a little bit of extra coverage. So maybe if mom wasn't in treatment when she was pregnant, maybe if we're getting the family a little bit later on down the road, they can still work with them a little bit longer than some of the others. Birth to three. Birth to three is based on the child having a qualifying delay or disability. However, if they're a member of a high-risk group, so for us, what happens a lot is if the child is exposed to substances prenatally, and that includes buprenorphine medication for substance use disorder. If they're exposed and they have neonatal abstinence syndrome or withdrawal, then that puts them into a risk category where they are more likely to qualify for birth to three, even if they don't have a significant delay. We strongly recommend families to get the evaluation, even if they don't qualify, just get that peace of mind. But if they do get services, they become a really big support system for our families, and they're also able to help with that transition when they're aging out of birth to three at 3 and starting into Head Start or pre-K. They can help them if there are still deficits to be able to get an IEP or 504 plan. So they really will hold the family's hand through that whole process. We really strongly recommend them. I think they're really underutilized. Sometimes people do conflate them with CPS. They're like, oh, CPS is just sending you to come spy on me in my home, but there is so much that they can do. So if that's another thing I would recommend. If your patient population or client population doesn't really know what birth to three does or has never met a birth to what's provided, and it's not just to scare you, it can really help a lot of families. And especially with prenatally exposed families, I strongly recommend that. And Head Start, which everyone I think on this call should be familiar with, the pre-K Head Start, but in our area anyway, our catchment area, they do have a pregnancy program where they will do home visitation as well. It's income-based, but if a child has a disability, they are given kind of higher precedence to maybe qualify even if the parents have a higher income than the cutoff. Okay. Another thing that folks may be eligible for, prior to or as part of initiating an in-home safety plan is the CSED waiver. I won't go into detail here, but I just want people to be aware this is something that ages 3 to 21. If the child is kind of at risk of residential placement and traditionally would have met criteria for targeted case management, so they have a mental health condition, but also deficits in 2 different areas of functioning that qualify, and they get the whole kit and caboodle. And these are services that I feel like were kind of discontinued for a period of time, but they can get in and they will come to you in the home, but they can get case management, respite care, peer parent support, in-home family therapy, and home family support. What I hear from parents is that they love it. All right, so as we are closing out, basically want to say, know your community resources, know which ones are co-occurring capable, so can they help both mental health and substance use at the same time? Are they receiving targeted case management? Because maybe you can work together and the parent be able to make more progress than they would on their own if they have already receiving targeted case management through their medical provider. Family-based services, you want to make sure that the folks you're working with are trauma informed and that you have proper authorizations for release of information as early in the process as possible, because if you wait until you need it, it becomes really challenging because people are trying to protect their license and they don't want to give you information that they know that you need, and it becomes a mess. All right. So these are, I believe, going to go out with the slides, so you have some example plans. I do want to go through at least one with you in our last minute. Okay. So Ms. B is a 30-year-old Caucasian woman with a long-standing history of opioid use disorder, 1 child in custody of their father via family court opinion, so not a prior termination. She entered an MAT program during her pregnancy, has been compliant with the program, and tested negative for illicit substances throughout her pregnancy. The biological father of this child is not involved, and her whole family lives hours and hours away. Due to her history, an in-home safety plan was implemented with the following services in place: continue her MAP program, continue with Mountain State Healthy Families, which she started during pregnancy, social support services at Lily's Place, so that was a secondary community support since she doesn't have family in the area, targeted case management through our DFMB program, and also birth to 3 referral, which although her child did not have a significant delay in any one area, he had 2 minor delays, and because of his being in a higher risk category from having NAS, he ended up qualifying and has not only caught up with his peers, he's doing amazing. He's one of the cutest kids that I have the privilege of seeing. But all these support services in place helped mom to be able to have a safe environment for this child despite her prior history. My contact information is on these as well, so please reach out to me if you have any questions or concerns. And thank you for your time, everybody.
Thank you so very much, Jennifer. Yeah, those slides will be in the content section in the iEcho, not in the recap email. We can't attach them, as you know now. So does anybody have any comments or questions? We can wait a little bit if you do. All right. Thank you very much again. So the only announcement I have is the next time we're going to be meeting is April 17th, and the topic will be best practices in drug screening. So we look forward to seeing you. Have a great rest of your week. Thank you.